we do have a machine called an ExoView,
Yeah.
which you can put a CD63 981 antibody on the surface, and it will capture this. And
Yes.
so theoretically, I can capture all the exosomes, but not every exosome has CD63, CD9. A lot of them don't have CD9 on them, And so it's the cargo that's in there that we care about. And so you're exactly right. I have to identify the cargo, not just the number of exosomes. So we don't even care anymore. We give you a particle number, but what we really care about is the RNA and the protein concentration.
Hey there, welcome to the Recharge Biomedical podcast. I'm Dr. Edward Park, and if you're curious about regenerative medicine, you've come to the right place. We're diving into the latest breakthroughs in telomerase activation, stem cell exosomes, and all the cutting-edge science that's shaping the future of healing and longevity. Let's get started.
Hi, welcome to another episode of the Recharge Biomedical podcast. I'm your host, Dr. Edward Park, and today we're very lucky to be joined by Dr. Duncan Ross, who is a PhD immunologist and the founder of this exosome craze. How are you, Duncan?
Good. How are you, Ed?
I'm hanging in. I wanted to give proper credit. So 10 years ago, they started making exosomes, but this is a field that's only about 17 years old. Asprey was joking that his conference is older than the annual exosome conference, which is only year 13. So this is cutting edge stuff. And somehow this gentleman who is a trained stem cell biologist was working with stem cells, and he had a doctor's wife who he was trying to help with her COPD, and the cells wouldn't copy. So somehow he thought to put the serum from the young man's cells into the old lady's cells, and all of a sudden, lo and behold, they started copying. So what made you come up with that little bit of inspiration? Was it an accident, or did you think?
Well, I mean, it was a lot of desperation because I'm not a physician, I'm a scientist, so I have to partner with you. And, he was my partner's wife, and I was trying to explain to them the benefits of stem cells and why I was necessary. And if I couldn't get her cells to grow, then I wouldn't be demonstrating myself as very necessary. So what I did know is that in the growth mediums that we use, there's growth factors. There's things like EGF, stuff like that, fibroblast growth factor. And you know that makes cells that are healthy grow. And so I had this 18-year-old paraplegic cells, and they were healthy and they were growing. But I had the 7-year-old cells in the same medium and in the same incubator, and they're not growing. So something must be missing, right? And so that was sort of a deduction that there must be something in the young one's cells that is different. And so let me just see. And again, it's not super ethical to be taking something from one person's cells and putting them on another person's cells, but because there could be pathogens or something in those cells. But I wasn't planning on using these cells anyway because they weren't growing, and so this was my last ditch attempt. So by taking the supernatant, so that's the serum or the medium, the conditioned medium that the cells were growing in, and putting it on the older cells, I slowly started to see these little dendrites growing from one cell to the other. But that required really, really careful attention, and I tried to have techs copy that in later years, and they say, I can't see anything. Well, because they're not desperate, because I'm paying their salaries. I mean, at that time, I'm paying my own salary, and I had to look very, very carefully. So I would come back and check every 3 hours, literally, to see that these cells were growing. And after a few days, I saw that they were growing, and I ended up being able to expand those to confluence in that flask, and then I split them, and I grew them again, and it was just amazing.
Amazing. Well, let's back up for the newbies out there who don't understand. So we've always known about cells, stem cells. Exosomes were ignored as cell poop, even though they saw them being excreted. So you didn't necessarily know that there would be exosomes in there, but for some reason you wanted to try it and it worked. So for those that don't understand, on the scale of 1/500th or 1,000th of diameter are these tiny little spheres. They're literally invisible, less than 200 nanometers. You can't see with a light microscope. And so it must be like the young music of the 18-year-old was singing to the old cells. And even though they're old cells and old dancers, they could still respond to the young music. So that's how I like to tell people, it's like they're healing like a newborn baby because these are isogenic. Unlike cells, which have self-antigens, your body doesn't know it didn't make these high-quality, potent exosomes, right?
And I think that, and we've done these experiments that, the cells take up the exosomes. And those cells of the 7-year-old, She has normal DNA, right? I mean, you could, I mean, there's nothing wrong with her DNA, except that her DNA was not expressing all the growth factors that the younger cell's DNA was.
Right.
So those exosomes then caused her DNA to start expressing normal growth factors, and so they started to grow. So
Isn't that
you're
interesting?
reprogramming basically the older
Yeah.
cells.
So we can presume that probably as a result of methylation, aka gene silencing, a lot of her capacity was shut off. But let's
Exactly.
pivot a little bit. So you guys are celebrating 10 years. Congratulations. So I met you over 6 years ago. I liked what you had said and I wanted to talk to you. You were gracious enough to have me join you for dinner. And since then, it's been a wild ride, up and down. A lot of competitors have come to market, many of whom have gone out of business. So, it's a very slippery kind of treacherous space. Everyone always comes and sends their detail man and they say, hey, doc, I can get you 3 times the exosome for half the price. And if you're a doctor and you're not really interested in the minutia, then you might fall for that. And a lot of people do. So when I went to the Exosome conference last year, I talked to the manufacturers of these counting machines and just cut to the chase. No one can directly measure exosomes easily. It's inferred from the Brownian motion of the particles. So a lot of these people just have the machine or get a lab to say you have so many particles, and they're claiming to have exosomes. So I think that's why, I was a little late to the interview because I had to give one of our friends some chimera exosomes. So I think that's why in the market, patients are actually asking for it by name. So what's your take on people who switch brands because they're getting more for less? Is it like gasoline?
Well,
Does everyone have the same potency?
I have a lot of takes on that. So one of my strongest competitors, who's no longer is, they made really nice marketing, which was basically copied from mine. When I saw it there, I was like, this looks a lot like mine. Well, they they sent out their first batch for particle testing, but then they never sent out another batch after that. They just
Oh
said,
man.
"Oh, this is how many particles we have," and they weren't using clean rooms and all these things, that you would not imagine as a clinician. I mean, when somebody comes in and sells you an exosome, you assume they're using a clean room, right? I mean,
Yeah.
well, there weren't. And when you think about there have been a lot of people, and like you said, that have gone out of business. My very first competitor, which was a company called USite in 2018, or maybe, they went out of business in 4 months because they contaminated 8 people with E. coli as soon as they started trying to make an exosome. And the FDA shut them down. And so that's what the FDA has been doing, is whack-a-mole, going and shutting everybody down.
I think rightfully so. Yeah. And, so people say to me, well, you're using this brand of exosomes. I use your brand. What about this FDA letter? And so I always tell them, FDA letter is like a badge of honor. If you're still out there producing and the FDA's come and looked down your throat and inspected, then you're probably pretty good. Whereas a lot of these companies, they have exosome products and they white label. They don't even make them, which means they have no control over the quality, the manufacturer. And like you said, you don't know what you don't know. So you may be having a working cell culture that's 6 months old. All those cells might have already shortened their telomeres, mutated, have abnormal karyotypes, and their exosome payload is poor or different.
You could expand the cells too far. We don't do that. The FDA made us prove that we don't do that. That's how we got approval. Yeah, you have people out there that are white labeling or marketers, and they're proud to say that they don't make the product. They also don't have FDA NDs. And so when you look at, okay, we got a warning letter. It said in there that we shipped non-sterile product. We did not ship non-sterile product. It's that the inspectors who came were kind of new at this. And I've actually heard a lot of stories in the past week about how these FDA inspectors come in and they admit that they've never done this kind of inspection before. They're going
Sure.
down their checklist, and the doctor who they're inspecting has to explain to them what they're inspecting. And that's basically what happened with us. And, I had to provide them later with the sterility report. And they go, oh, okay. Well, they didn't take down the warning letter, but I have to live through it. So, but then they came to inspect us again in August, and they were there for one day and left. So the bottom line is, if I'm still in business, if you're still interviewing me, that must mean that I don't have a problem with the FDA, because otherwise they would have put yellow tape around the building. Right?
Exactly. So, but let's talk about whether this is legal, because a lot of people conflate the notion of legal, ethical, FDA approved. So
Right.
just because you have an IND, there are certain restrictions you can still place on a company that's producing exosomes. So we have to be very careful both as as you as a producer, how you're marketing it, and me as a physician, I mean, there is a lot of consenting that goes on. This is not FDA approved. This is not standard of care. An IND doesn't mean really that it's going to be safe or effective. So I'm basing it on 3,000 plus treatments over 6+ years. And I always tell people, look, there's a lot that can go wrong. You know, you and I could make up a home brewing kit for beer and it might be okay. But would I drink my own beer, you know, year after year, quarter after quarter? There's quality control issues. So take us through the steps in which a product can become compromised at a cellular level, foreign microbial, like what can go wrong?
Well, if you can equate it to the expiration date that we put on the vial. When you first make a vial, you don't know what the expiration date is, right? I mean, you have to go every year and retest the product, and then you can go extending our expiration date. So because we've been in business for so long, we have so many lots going back, we now put 3 years on the vial because we have lots going back more than 3 years. And if you have those lots, and those lots have always been sterile, and the cell line was tested in 2018 when we made it, and afterwards for the FDA, and we had to test it for hundreds of viruses versus tissue products that you might buy now that are called exosomes. They only have to test 12 different viruses. So there could be tons more things in there. And that's what the FDA required for our IND approval. So when you have 10 years of history and 10 years of safety, that really says something, because an exosome product can come on the market tomorrow, and this is what happens. And they take umbilical cord, blood, and they spit it down, and then they call that an exosome. And it takes them about 24 hours to do that. The blood comes, they package it, they send a few off for sterility, and then they sell you the thing. But you don't know that those other vials are not contaminated.
Absolutely. Yeah. I mean, that's why, you know, I was talking to a patient last year who said exosomes have been huge in Japan. But again, some people died from a bad batch from an amateur manufacturing process, and that just takes the whole field back, just freezes it in its tracks.
Right.
Because it gets labeled, you know, exosomes kill people, right? So
Right. And then when the FDA comes in your lab, they don't know anything about exosomes. They just think exosomes are dangerous. And so it's taken a lot of convincing, I think, to get them to where they are.
Yeah, I mean, every other week I get a manufacturer saying, hey, doc, we want you to try our exosomes. And I'm like, well, listen, at the end of the day, if I'm not going to put it in my body because I don't know how you make it, that's a problem. So why should I put it in someone else's body? I mean, this is an example of what I got today. And just so you know, it's expensive, but you don't have to do it intermittently. Every batch has to be, of course, tested for fungus, endotoxin, sterility, potency. But just to give you a list, there's almost 40 things: Hep B, Hep C, HTLV, CMV, syphilis, Zika, malaria, you name it. And I've heard from, you know, good-looking people in suits that, hey, the more donors you have, the safer it is. And that couldn't possibly make sense. That's like saying, well, the more sexual partners you have, the less likely of an STD. So there's a lot of people who really don't know what they're talking about in this space, and they're just pushing product.
Right, and you just mentioned Zika and malaria. That's not something a tissue provider has to test. And you're right, because of the way I did it, I only had to do it once. It still cost me $1 million to do it, but I only had to do it once. So when a tissue provider does it, they're not going to spend that $1 million in every lot. They only get 300 vials out of it. So it's just not cost effective. So it's more expensive for me to do it my way, but it's also safer.
Yeah. I mean, and, you know, I know that you have proprietary intellectual property and things that you do, but without getting too much into that, you know, a lot of the vendors, they don't do size exclusion, size inclusion, filtration, and then resuspend them in pure normal saline. So we're not getting like exosomes. We're getting a lot of particles, which could be good, could be bad. You know, when we went to the international science thing, I asked the question, well, what's in the bigger ones? What's in the smaller ones? And it might be the same kind of content, but the smaller ones, less than 30, 40 nanometers, exometers, typically those are not the ones formed in the cell that we can see. So you took a very conservative approach. But now there's people in the marketplace selling just controlled media, and they've been doing that. And one of your competitors that was pretty popular for a while, I remember talking to him, he said, oh, ours are 300 nanometers. This is much better than 100 nanometer canonical exosome or standard exosome. So I thought, yeah, that makes sense. Like whatever, 4,3 pi r cubed, that's bigger is better. It might be better, but again, it's not the standard exosome that's produced in the endosomal multivesicular bodies. But what are your thoughts on these people that are marketing just controlled media, first of all?
We age because our telomeres shorten and our stem cells deplete. But what if we could support both? I've been taking TA65 for 17 years. It's the only supplement I trust to support better mood, better sleep, and exercise recovery. And at age 57, I don't have any gray hair and I don't need reading glasses. TA65 is available now. Go to rechargebiomedical.com/TA-65 and enter promo code RECHARGE10 to save 10% off.
Well, condition
media.
I
Sorry.
just spoke to somebody today who, they were sold quote unquote exosomes. She took it IV, and then afterwards they told her, oh, it's the secretome, which means conditioned media, but didn't tell her that. Now, I'm not taking conditioned media IV. That's dangerous. I mean, the reason that I isolate the exosome is specifically for purity and safety sakes for a reproducible product. And you're right. I mean, you may be able to demonstrate that a 300 nanometer vesicle is better, but you need to demonstrate it first. I mean, I don't care what the size is. I have 10 years of reproducible data from guys like you that I know exactly the dosage of my exosome. So science alone is not going to come up with an answer for you. You must have outcomes. And we've had...
Well, that's the thing. Yeah, I mean, I remember Stella Corumbatis, who did a lot of stem cell and then exosome research with premature babies at Harvard. I remember listening to a video, and I picked up on what she said. She's like, well, we don't really know. Like, we know we have around this many cells. You can count cells. And we know that in 24 hours, they produce this conditioned media. And if we do our process, this is like what we're estimating and using the nanosite to confirm, it's around this many billion, like millions of cells, billions of exosomes. But there's nobody in the world, and I'm going to get another manufacturer on in a couple of weeks who I met, and we're going to talk about, because he says he can count the individual exosomes. Now I want to challenge that. But everyone has an estimate based on your standard operating procedure, how many exosomes are in there. But you do one other thing that you invented, which is to, of course, everyone has to melt the exosomes to crack them open and see what's in them. So you actually have a quantification of the yield based on the mRNA and over the protein. So that's actually a measure of potency, because let's be honest, no one can actually give you a precise number of exosomes. They can guess the number of particles.
You can ask him this question. We do have a machine called an ExoView,
Yeah.
which you can put a CD63 981 antibody on the surface, and it will capture this.
Yes.
And so theoretically, I can capture all the exosomes. But not every exosome has CD63, CD9. A lot of them don't have CD9 on them, And so it's the cargo that's in there that we care about. And so you're exactly right. I have to identify the cargo, not just the number of exosomes. So we don't even care anymore. I mean, yeah, we give you a particle number, but what we really care about is the RNA and the protein concentration. And somebody who is trying to qualify, or I don't know if he's trying to reverse engineer or qualify exosomes, like, well, we're looking at the CD81 content of your exosomes, and he was asking me questions about that. I'm like, well, I don't know how you're looking at that. I don't know what antibody you're using to look at that. We've refined this over many, many years, and questioning me on the lot-to-lot reproducibility based on the amount of CD81, that doesn't make any sense, right? And so our response to him was, well, the RNA concentration of the lots was the same and the protein concentration of the lots was the same. So, I mean, he was trying to say that the newer lot was less effective. I mean, but he didn't even use the newer lot yet. He just...
Yeah, no, and bravo to you, because this is the cutting edge, the bleeding edge of science. You had to make up your own equation for how to crack open the exosomes and measure the potency. So this is like science that doesn't even exist yet. It's not readily adopted, but when you hear the scientists at these conferences struggle, they could probably adopt your method of bioactive units, and it would help them measure. But again, I think the problem is that people don't understand what they don't understand. So because of the practice and the QA over 10 years, you've had to invent stuff that no one else uses. So you're always at the cutting edge of quality assurance. And so people just don't get it. They think, well, if I buy gas from Chevron in Texaco, it's not just gas. Like, how different could it be? Mm-hmm. But I say to people, the devil is in the details. Like, it's not hard to make an exosome. The stem cells just make them. Mm-hmm. But to do the QA and validate the potency and the safety, totally different ball of wax. Now, make a comment on placental matrix, Wharton's jelly. How safe? What is that exactly? Because I know that the source of your MSCs or your Django FET stem cells that you clone and store, that's from a placenta. I don't know if it's cord or parenchyma, but we're talking about something that's not trophoblast. It's not from an aborted fetus. We're talking about a live-born donated C-section clean placenta. What's the reason that people are injecting tissues, placental tissues? Is that safe as an immunologist?
Well, the answer is that the person who provides it to you, their answer is going to be, well, we believe fresh is better than the way Duncan does it, which is expanded. But I believe fresh is dangerous. And so placental matrix or orange jelly is a ground up, really in a blender, ground up tissue that you then add saline to, and then you try to filter it out or not filter it out or whatever, or spin it down to try to get the bigger chunks out of there. And that's what people are selling.
So obviously it's going to have stem cells in it. They're not collagenating it, but there's a ton of stem cells in there. But then again, it's going to have immune incompatible MHC antigens, right? So your body's going to have some type of reaction, host versus graft.
Right. That always freaked me out because, I mean, that is what my PhD is in, is that rejection. And I know that, a lot of times you'll get by with the patient not responding, but sometimes the patient's going to respond. 0.01% of the time, the person is going to respond. That's called a superantigen reaction to that HLA. And it's going to happen. It's just a matter of when. So now you got two problems with using fresh tissue. You've got this rejection that you just mentioned, and you've got the potential for contamination that I mentioned before. And those are two possibilities too much for me.
Yeah, I mean, hypersensitivity, I get asked a lot, never seen it because it's so immune sensitive. And people will say, well, I'm doing allogeneic stem cells and they're immune privileged, but I can't get a straight answer. Is there engraftment? I don't think so. I mean, most of the people will say these foreign cells that you're taking may last for a while and secrete their exosomes, but I think they talk out of both sides of their mouth when they're saying, oh, yeah, they do engraft. Of course they survive. What's your weigh in on that?
Well, there's a reason that there are no FDA-approved cellular therapies like that for engraftment, and that's because the FDA doesn't. First of all, nobody's been able to make it reproducible enough to get past phase 3, and second of all, the FDA doesn't like DNA in products, period, because that offers the opportunity for integration into the genome, and they don't want that.
Yeah.
So I can tell you that third party, I don't care if they're not immune privileged. They won't get rejected as quickly, but they're still going to get rejected in a period of 9 to 12 hours versus 3 to 4 hours that, like, say, a macrophage would get rejected. So, that's just not true. That's intravenous administration. I have seen studies where if you put the MSC in sub-Q, it gets rejected over a period of days, but it definitely gets rejected.
It's harder to track down in the tissue.
It's harder for the immune system to get to it.
Yeah.
Right.
And a lot of it goes to the lungs, trapped in the spleen and liver. So, I mean, that, and people swear by it, and the margins are good. They pay a lot. They go to Panama, spend 15, 20, 30,000. Who knows? Anecdotally, the patients have no reason to lie, not much anyway. And so I don't think the response rates are as predictable as with exosomes, which is, if we're being honest, how the stem cells are working. Right. One more thing that's in the market is amniotic fluid exosomes. And, I have used that with great success on hair regrowth in one N of one. But I have to say that, when we first met, I told you the story about how I had a patient as an OB that almost died from an amniotic fluid embolism. If it wasn't for the anesthesiologist giving them blood, platelets, clotting factors, I mean, her heart rate was down to 60, her SAT was down to 60. She was dying and she was bleeding from everything. So that could only have been an amniotic fluid embolism. So right. Naturally, I'm a little hesitant to use amniotic fluid products, but there are some people on the market that tout that, and they actually, I mean, what are they even doing? They're collecting amniotic fluid and just repackaging it, or are they even testing it? Are they filtering it? What's your impression of those products?
Well, I used to make those products, right? And I was filtering them. I never suggested them for intravenous administration for the reasons you just mentioned, because regardless if I'm filtering, I mean, you can have a ball of vernix this big, or you can have a ball of vernix this big that still gets through my filter, but it's still there. And it can agglomerate with other ones when it gets through the filter when you inject it. So that just terrified me. But that's not even the reason I stopped making amniotic fluid, because I was making amniotic fluid for intra-articular injections. So I wasn't so worried about the embolism. I know the companies out there right now are selling it for IV like it's no big deal. It is a big deal.
I would never,
It's just cheap and easy to make, and these companies don't want to admit it. And so, but the real reason I stopped was, and this happens to us with manufacturing exosomes. If we change stuff, suddenly the exosomes won't have RNA in them. And when they don't have RNA, we're not going to sell it because we know it's not going to be functional. For some reason, amniotic fluid exosomes did not have any RNA in them, and I cannot tell you why. There's CD81 there, there's growth factors there, but there's no RNA. So that's why the amniotic fluid exosomes are not long-term regenerative. And the way one of our docs actually tells the patient is, it depends on how much money you have. If you want me to treat you with amniotic fluid along the facets, you're going to get about 6 to 8 months worth of relief. If you use these exosomes, you're going to get a year to a year and a half worth of relief. And that's because of what I'm saying. It's that remodeling of the DNA that's lasting longer than an amniotic fluid exosome would.
Isn't that interesting? Now, in the field of winemaking, they say that a bad year in terms of climate and stress on the grapes makes for better wine. Are you finding, without divulging your secrets, that, because I would think that there's some level of consciousness and agency in these cells. So if they think everything's cool, they might not work as hard to make, anti-inflammatory regenerative exosomes. Is there any truth to that, or is that just me hallucinating?
There's some truth to that. If you grow them in low oxygen, if you stress them other ways, then you get different exosomes. I mean, mine are slightly stressed. There's other ways to stress them. But again,
do you have a playlist for them, or
Tchaikovsky? No, but again, it needs to be reproducible. So I have FDA approval for this one. I can't change the way we're stressing it. Otherwise, I have a different one. And I can promise you that the microRNA formulas would be different if I did that. And so we know what we've got. We love those microRNAs that we got approval by showing lot to lot they were the same. If they were all over the place, we wouldn't have gotten approval. And so that's the issue with a secretome or with cells is it's all over the place. And then the FDA doesn't know what to do with that,
Yeah. No, I mean, I think that a word that people might not know is X, right? The study of. So you have to crack open the exosomes with soap and do the omics, RNA omics, which is two kinds, messenger RNA and micro-blocking RNA. But there's also proteins. So in the grand scheme of things, there might be some little bit trace DNA and lipids, but mainly that's the payload. So when we're thinking about this, like, give me a ratio, micro to messenger to proteins. Like, what is it? 1 to 1 to 1, 1 to 3 to 1?
More micro than messenger. And there's a bunch of proteins. And you're right. The first time I did a protein omics, I did it with and without soap, like you're mentioning, and I thought I was pretty smart for knowing how to do that. But that's stuff I learned in biochemistry. It's not stuff I learned in cell biology. That's why the 2 PhDs were important. I got different outcomes. So, there was proteins that are floating around, and then there are proteins that may be attached to the exosome, then there's proteins inside the exosome. And it's just a pain to look at all these different things, but you have to, But
they talk about the corona, and maybe that's a huge part of the function. Yeah.
I compared the MSC exosomes to the amniotic fluid exosomes, and they were completely different growth factors.
I saw the readouts. Yeah, no, absolutely. So explain to us, I mean, you're doing the science, you're scaling a commercially available product. You're kind of counting on us doctors to not mess it up for everyone. But explain the staff that you have there, because, I hear rumors of people that have moved from lab to lab, manufacturer to manufacturer, and they're like, we were like in a kitchenette in a strip mall next to the check catching place, So you guys have a big facility, a lot of employees, 6 PhDs last time you counted?
We have 50 employees. We have about 6 PhDs. We have a lot of manufacturing technicians that came from other big laboratories. And they're special and kind of hard to find. They need to be happy to do something the same way every single time. And I have to do a lot of things to keep them happy. They have a 4-day work week, for instance. I mean, that kind of stuff. But it's nice to have them. And for good or bad, I might complain because it really eats into our bottom line. But for everything we do, there's like 3 people doing it. There's how many Kimera technicians does it take to screw in a light bulb? Well, it's like 3 or 4 at once. 2 people watching one of them work.
Oh, I mean, that's kind of what I grokked. It's like not hard to make an exosome, but if you're going to do it out of a strip mall in Orange County, then it's going to come and catch up with you. You're not going to And that's just what my intuition says. From the moment I met you till now, you just pretty straight shooter. So in the future, when can we get tissue-specific exosomes? I know it's something you kind of had your thoughts on, but like, let's say, chondrogenic originated or neuro stem cell originated. Is that coming down the
I
line?
think the chondrogenic one is coming really soon.
Oh.
I did have lots of different tissue exosomes years ago, but some of those were from fetal tissue, and people don't like that. So that's why I focused on the placenta, because it was the youngest ethical cell source I could get. And a chondrocyte is also going to be from an adult. So that's doable. So I want to do that soon. I'm looking at some other cell types, but we'll see if they're any better. We looked at neural stem cells, and we didn't see them to be more effective than the MSCs and what we were doing.
I mean, I think the MSCs, they do well in a lot of different scenarios as nature intended them and as we use them every day.
Right.
But if we're going to wrap up here, I know you've had this thought to have joint ventures to submit to the FDA, like let's say infertility, Crohn's disease, COPD. And so you're starting to build a structure where investors can come in and partner with you. So that'll look like, well, we get the indication if it's approved by the FDA, and hopefully they won't use their very ham-handed, like small molecule model. They'll see the safety, they'll see the efficacy, and they'll get the dosing. But if those go to market, it could be profitable for a potential investor. So if somebody was willing to take that biotech plunge with you, how soon can they get on board as venture capitalists partners?
Well, actually, within weeks, and you just mentioned some of the INDs. And so what I'm looking for is individuals who have a background in that field who are going to be able to take it further. So, I mean, you have a big background now in all kinds of things, but if you took you years ago when you were just finishing your OBGYN, okay, well, I'm trying to do an ovarian health IND. You would be a good person to head that. And I'm looking for $15 to $20 million per IND. And then people would get their shares, and we'll move it forward through trials. And as we get to phase 3, maybe we'll sell that to pharma. Maybe it's something that we want to keep. I mean, it's.
But wait a second. Are you looking for people with science and clinical touch points, or can someone just with money come in as a limited partner?
Well, somebody just with money can come in as a limited partner, but I also like to think of who might be the right CEO for that particular project.
Right.
Yeah.
So I know somebody in one of the local universities who's been doing exosome research for 6 or 7 years, and she runs a lab, is an MD, PhD. That might be a good partner for you, for example.
Exactly.
And she'll have her own funding sources, I'm sure, from third party. Okay. Well, very good. I mean, doing a lot of exciting things. I know it's been a really, really rocky road for you, and there's been a lot of stress. So congratulations on, as Elton John said, you're still standing.
We're almost there. I was feeling good.
All right. Well, I know that your product has changed my life, my mom's, my son's, and a lot of my patients. And I feel that it's a very safe and effective one. I mean, does it always work? No, nothing always works. But again, as far as injecting it into people, which is not FDA approved and not standard of care, I always say no thanks to the other products to date. So that should tell you something.
Well, I appreciate your support.
Absolutely. So keep it up and we'll talk.
Okay.
So, if they wanted to get in touch with you, what would be the best way? Obviously, there's Kimera Labs, but if they're interested in investing?
Duncan.ross@chimeralabs.com.
There you go. Duncan.ross@chimeralabs.com. All right. Thanks a lot, Duncan. Appreciate it.
Thanks for tuning into the Recharge Biomedical podcast. If today's episode got you thinking, you'll love my book, Exosomes, Songs of Healing. It's packed with cool analogies, full-color illustrations, and all the science you'll need to understand how exosomes are changing the game in aging and regenerative medicine. You can grab it in paperback, ebook, or audiobook, whatever works for you. Now head over to www.rechargebiomedical.com to check it out. And don't forget to like and subscribe so you never miss another episode. See you next time.